So hi and welcome to the very first Midwifery Wisdom birth vlog review. My name is Augustine Colebrook. I'm a midwife and a mentor and a muse. I'm also a grandma, don't tell anyone, shh. And I work with a team of amazing, supportive administrators and experts, copywriters, graphic design artists, business people. I even have a lawyer on my team. And we help support midwifery practice and business in the United States. And we help to educate mamas and midwives about the normal birth process. So we've decided to do this vlog series. I've invited one of my administrators, my audio visual expert, Miss Bekah, to join me today. And we're gonna watch a pretty popular birth vlog that's out there on YouTube for public consumption. And we're gonna look at both what the mama is doing, what she's experiencing, and we're also going to look at what the midwife is doing, and we're going to chat a little bit about midwifery care. So I hope you'll stay tuned and check out this cool birth vlog. Hey, welcome, Bekah. Thanks for deciding to join me on this fun adventure.
Hey, Augustine, I'm excited to watch with you and learn from your wisdom.
Yay. Well, so Bekah, will you do a little intro? Who are you and where are you?
I'm Bekah. I'm Augustine's audio and visual editor. I work on her videos for courses, for YouTube, podcasts. I get to hear all of the juicy goodness she has to share.
Awesome. Well, we're gonna have so much fun today. Today, we picked a video that's gotten over 7 million views, which means mamas out there really want to know what this is all about, and they're watching people do it for real in real life on vlogs to try to unpack what this whole home birth thing is all about. So we're going to try to take that beautiful edited video that she created and add a little bit more sprinkled midwifery wisdom on top. So you can check us out on social, midwiferywisdom.com. And then we are all over Twitter and Instagram and Facebook at Midwifery Wisdom. Come check us out. And of course, here on our YouTube channel. So make sure and subscribe below. Hit that like button if you like what we're doing here. And also send us some messages of other birth vlogs you'd like us to review. All right, without further ado, let's get started.
This is probably my last pregnancy, and I'm honestly, I think I'm really excited about that. I feel like I'm...
Those are such famous last words. This is my last pregnancy.
7 weeks.
Oh, look at that cute belly. So that really quick clip of her belly with the baby moving is kind of an interesting aside. Obviously, midwifery is not all about the birth. Midwifery is about prenatal care and nutrition and holistic education and couples and marriage. And, you know, we go into every part of aspect of life. And one part that I feel like is vitally important and that a lot of mamas don't understand is that position of your baby makes a huge difference in the course of your labor and delivery, in the comfort of your pregnancy, and honestly, the success of a normal natural birth. And so one of the kind of dead giveaways that something is not optimal is when there is movement right in the front of your belly. So movement in the front of your belly means that there are feet and arms, knees, elbows at the front, which means the back must be opposite where the small parts are. If you can imagine, I have my trusty little guide here. If you can imagine how a baby is positioned in the womb, that like fetal position is what we're always talking about. So if there's little small parts out front, that means the back must be to the maternal back or the birther's back. And when that happens, the back of the occiput, the back of the baby's head, presses on the sacrum. I have a nifty pelvis here too. Things only midwives say, right? So when the baby is facing out, the back of the head is pushing on the sacrum, and that causes something called back labor. It also means that the head is not as tilted or as flexed as it's supposed to. So in a normal birth, the head is completely flexed with the chin to the chest so that the crown of the head is presenting. But in a posterior baby, or that face to pubes, sunny side up, back labor, all of those refer to the same situation. In order to negotiate the pelvis there, the head automatically gets less flexed. And so when that happens, the chin is not to the chest, it's out. And then we have an oval shape presenting at the round cervix. So this is my pretend cervix here. So the cervix is a round muscle. And when the deflex posterior baby comes onto that, it's putting pressure at 2 points instead of evenly all the way around. And those 2 points cause uneven dilation, can cause a cervical lip, can cause bleeding, can cause dysfunction, pain, et cetera, et cetera. So there's a huge motivation to try to get a baby in a proper position for a normal labor and delivery. And by no means is a baby locked in position. In fact, they move in the pelvis, spin, as the famous Spinning Babies website refers to, is that they can spin in the pelvis. And they're by no means locked in that posterior position, but maternal position greatly influences fetal position. So in our modern culture, where we're like leaning back on couches, crossing our legs, using ottomans, futons, bucket seats in the car, ottomans, papasan chairs, basically every way that our modern life is designed, it's designed to tilt the pelvis backwards. And when that happens, the back becomes lower than the belly. And because the heaviest part of the baby is its head, about 97% of babies are head down at term. But if the back is lower, then the next heaviest part of the baby, which is back, fills the mother's back or the birther's back. And this causes that back labor. So in pregnancy, it can be a really great idea to remember optimal positioning for your body, which gives optimal positioning for the baby. So we want to have the knees below the hips, which tilts the pelvic brim forward and causes a nice round belly in the front. And then the baby's back will fill the maternal back, which is much more comfortable for pregnancy, honestly. Have a low curve in your low back and have a nice round belly out front. It's more comfortable for the baby. That's their optimal place of being, just off to the side or tilted to the front. Either of these are optimal for the baby. And then of course, it's a much more efficient normal labor.
So if a mom experiences any back pain or back labor, I know that's something I experienced quite a bit with my first, is that then, can you not experience back labor? What am I trying to say?
Can you experience back labor
even
baby?
if baby is in a good position? That's not like a sign that baby's in a bad position, or?
It's not 100%, but it's definitely a good indicator. So you can get back pain because of an elbow up. So some babies come down with like sucking their thumb or their arm even up behind them. And this elbow can cause a significant amount of back pain. You can have back pain because of a tilted uterus. So the uterus is actually a free floating organ. It sits in the pelvis and then grows up into the abdomen throughout pregnancy as the baby and the water grow. But the organ is actually a free floating organ, and it's only connected in 3 spots in the pelvis. So the uterus sits in the center, like about the size of your fist, kind of in the center of your pelvis, if you can imagine like that. And there are 3 round ligaments, 1 that connects to the sacrum in the back and 2 that connect to the very front of the ischial spines, or the pubic bone, not the ischial spine, the very front of the iliac crests out here. So as that uterus grows up and out of the pelvis with a big baby in it, it yanks on those ligaments, and they're not very stretchy. Ligaments start out about 2 inches long, and by the end of pregnancy, they're about 11 inches long. So it can be very uncomfortable to have the tugging and pulling on those ligaments. And if you start pregnancy with your uterus tilted forward or tilted back, as it grows up, it will pull on the shorter ligament, wherever that is. So it could be that you had back pain because your uterus was tilted back. And so then when it got full of baby and it was growing up, it was yanking on that back ligament.
Okay. Yeah, makes sense.
Yeah. Good question. 37 weeks and 4 days, which is just inside the due window. Ooh, she looks labory.
Baby has really changed position and gone like all forward, and my belly almost
Yahoo! That's what we wanted to hear. Her baby changed position. And sometimes that early labor is what rotates that baby. Yep. got that early morning surge. So there's a hormonal surge between 2 and 4 a.m. and 2 and 4 p.m. So that's normal times for labor to start, or for labor to increase in intensity, or for babies to be born. Those are really big hormonal shifts. I just love that she thinks that this is false labor. Moms are just so adorable in their not wanting to get their hopes up and not wanting to get overexcited for that day they've been waiting on for so long. It's really actually pretty sweet. False labor is not really a thing. False labor is a invention of disappointed moms and or negative providers, and we really need to stop saying it. Every contraction does something, even if we can't measure it, right? So in obstetrics or in midwifery, we can measure dilation, we can measure effacement, we can measure station, and we can see the position of the baby. But we really can't measure much else. Like, I can't measure if your emotions are ready for birth. I can't measure your cervical ligaments and how those are changing. There's so much that goes into a birthday that we can't even measure. So every contraction does something. All those sensations are leading up to an effective process if we just learn how to welcome them. And this particular video of this particular mama, we know that's not false labor for two very important reasons. Number one is that she is in what we call labor land. Bekah, did you see how her eyes are kind of like floaty and kind of closey? And if you listen to the audio, she just is saying sort of nonsensical things. She's like, I don't know if I'll do this forever. Like she's just in that labor land place.
My mom calls it an out-of-body experience. She said she felt like she was like floating over her body, looking at herself when she was in that stage.
Yeah, exactly. So you can tell that she's in labor land because of her spacey voice, her droopy eyes, her not quite normal control of her body. Those are all signs of labor land. And that is a really good sign. That's progress. We love that. We know that that's not false labor. You can't be in labor land without being in active labor. The other way that we know this is not early labor or false labor is because the contractions make her move. So in early labor, your body wants to hold still. You get a contraction, you go, ooh, this one hurts. This one hurts a lot. Okay, whew. That one's gone, great. You move between the contractions. But in active labor, you can no longer sit. You have to move your body. And so when we see these few clips of her in labor in the tub, and by the way, no one really wants to get in the tub in early labor, but she's in the tub and she's having to grab onto her partner and pull herself up and rock her hips. And we know that that means you're in active labor. So it's very clear. All mothers can recognize this in their bodies. Early labor makes you hold still and kind of clench. Active labor makes you move. It makes you get active. So I love that she thinks she's in false labor, but now that you see it, you can really see it. That's not true at all. Yeah, there's that labor land face. Midwives can just see that. We just know she's in active labor. I would guess probably 6 centimeters right here, just from her behavior and her eyes, her sounds. You can also see her whole uterus bunch up below her ribs. When she's having contraction, it gets really tight and pronounced. And so midwives can watch that from across the room. We can even sort of see the intensity of the labor in her body, in her eyes, in her movement. It's really amazing.
I feel like I'm just having contractions. I don't feel like I'm in like labor.
And we know, of course, from the famous Ina Mae Gaskin midwife in Tennessee, that what gets the baby in gets the baby out. So I love partners who smooch on each other and love on each other in labor. It definitely flows the oxytocin and allows the labor to go smoothly. One of the best ways to labor normally is when you feel safe, and your partner is generally the person you feel the safest with. And so getting to be intimate and cuddly with them is so great. I love that midwife Shannon has arrived, and I love that she's identified that way. Like, we have Dr. Smith. We should have more midwife Shannons and midwives as called midwives. I love it. But the first thing a midwife, a skilled community-based midwife does is they come and check your baby. So fetal heart tones tell us how baby's doing in relation to the changes in the uterine environment. So when you're pregnant, baby moving, midwife touching or ballotting your baby's head, you touching your baby, or practice contractions, all in pregnancy, are changes in the uterine environment. They're very slight, they're very minor, but the baby should have some kind of response to them. We call that reactivity. In labor, when the contractions come or when the water releases, that's a change in the uterine environment. And those changes really tell us how baby is doing, because we listen to the heart rate during several contractions. So the first thing we do when we arrive to a birth is to say, this mom is doing okay. I can look at her, I can hear her, I can really assess her visually. How is this baby doing? And so the first thing a good midwife will do is get out her Doppler or send her senior student in with the Doppler and listen to that baby. And we have waterproof portable devices that can listen in any position that the birther is comfortable in. And then we can actually move with each contraction or the motions that need to happen to get through the labor. And it's waterproof, so we can listen in the tub or in the shower. And that's a really important part of community-based birth, because when we have healthy, full-term, well-fed moms and babies, we have moms and babies that do just fine in labor. Like, nobody has an issue, they have normal birth. But the only way the baby tells us how they're doing is with its heart rate, specifically in relation to those changes in the uterine environment. And so listening is one of the very first things we do when we arrive. We really want to make sure they're doing well. And then this is exactly what this midwife is doing. We're going to find a heart rate somewhere in the normal range. And the normal range for a term baby is 110 to 160. And we listen for long enough to determine a baseline. And that baseline is kind of like that baby's average. And then from that baseline, the baby has a range, and that range is 15 beats above to 15 beats below. And any heart turn that we hear in that range for that baby's baseline tells us that the baby is normal and doing well. If we hear a heart tones at future listenings during this labor for this baby outside of that range, then we know we need to figure out, is there a change in baseline? Is this baby bradycardic or tachycardic? Are they having accels or decels? And where in relation to the contractions is that happening? So obviously fetal heart tones monitoring is not a particularly simple process, but it's very, very important. There's a good heartbeat. So we like that sound. We would have probably wanted to listen longer, but I think this midwife gets how fast this labor is going and how she probably has none of her equipment in the room. So she verified that the baby sounds in a normal range and now has run to get stuff together. And we're going to see how important that is in just a minute. Yep, our guess of being 6 centimeters a few minutes ago was probably exactly accurate. And we know that this is a multip. This is not her first baby. And we know that multips tend to have faster labors than primips.
Thank you, Lord. Thank you, Lord.
I'm so happy to have progress. Oh, she's in transition now.
It's not that bad, but it's so bad.
I know,
That's the best quote.
Classic. Best quote. That is exactly labor. There's no English word that describes the sensation.
I don't want to push. I don't want to push. You want to tell Shannon that? I want to push.
So I love how she talks about her need to push, and this in an unmedicated labor where you feel supported and loved and you're not afraid. There is absolutely every possibility that you can feel your way through labor without any external guidance. And in fact, many midwives in the United States and in other countries will help support a labor without really ever intending to do a vaginal check. So checking vaginally and checking the cervix, like we just saw happen, oh, I'm 7 centimeters. There's certainly nothing wrong with it. But there's also not a huge benefit in many, many labors. And this is not a criticism of what's happening in this video, because there was a fast labor and the mama did want to know, is this false labor? And the midwife had just arrived, and I can see lots of reasons why it was a useful tool. But that's exactly my point. It's a tool. It's a tool to help us get information. And so for the midwife and for the birther, the question is always, what are we going to do with the information? If the answer is nothing, just labor, then it might be a useless assessment. If we're going to say the midwife's going to stay and set up and have a baby, that's a really good reason to have that data. If the mom suddenly feels like she has to push, and we want to say, is it time to push? That would be another great reason for an assessment. If labor has been going on for a long time without any visible progress from the outside, then an exam could be a great idea to help figure out a malposition of the baby or figure out how to help labor progress. But to do it routinely is really, really kind of unnecessary for an unmedicated person in labor. And as we can see here, she very quickly from 7 is going to complete and feeling that pressure of her baby moving down, which is a totally normal sensation. It's really unmistakable. Some people says it feels like you have to take a poop. It's a huge amount of pressure in your bottom, and the pain changes. The quality of the pain of labor changes. So dilating is an all around, if you have a normally positioned baby, is an all around intense, burny, stretchy, sharp, oftentimes focused at the very front of the pubic bone or between the hips. And it is kind of like, it feels expansive versus second stage, when the baby starts to move through the cervix and into the birth canal, into the vagina. That feels like downward movement and pressure, and the sharpness goes away. It becomes really dull. So I love that she's announcing that. I'm sure that midwife is scrambling to get her ambu bag and her cord cutting equipment and her gloves and getting all the things. She's probably frantically calling her backup or her second assistant midwife, who's not there yet, I think, and getting ready to help catch this baby. So let's see what happens.
One or the other.
Yeah.
Oh, there he is.
Baby's here.
Okay. Leave baby up. Leave baby up.
Pull it up.
Hello. Leave baby up and off your chest. Okay. Oh my goodness. Oh. Hi, baby. Hi.
Did anyone see that?
625.
I love that. Did anyone see that?
But that is the degree of shock that, like, when a new person joins the planet in a normal birth, it is like 1 minute they're not here and the next minute they are. And it is that magical. Like, you can almost not believe what happened. And I just love this video, partly because of this really adorable birthing person who is just innocent and sweet and connected and present and just flowing with the labor. She obviously has almost no fear. She's very connected to her partner. She knows what's happening in her body, and she's just literally going with the flow. I love that part of it. But I also love the autonomy and the sovereignty. Like, when her midwife arrived, she didn't come in, she didn't boss her what position she was supposed to be in. She didn't bring any fear with her. She didn't even give any suggestions. And when the baby comes out in the water, she says, lift your baby up. That's all she says, which is like perfect. And of course, that's what the mom's doing, is pulling her baby up to her chest. And that, you know, we really can catch our own babies. We really can be in the driver's seat of the whole process. And this is something like almost all midwives absolutely believe and support. It's that, you know, there's this famous midwife in Australia. Her name's Hannah Dahlen. She's a professor at Western Sydney University. And she has this great quote. She says, midwives should be Sherpas, not usurpers. She said it in her great Australian accent. I can't quite say it. But we're not usurping the process. We're not taking anything from you. We are simply helping to show you the quickest, most direct route to reach the summit of the mountain or of your labor. We've taken the path before, and we help to carry some baggage too. And I love that image. And here's a perfect example. The midwife quietly came in, assessed the baby, got her equipment together, and then was there to help dry off the baby and assess that the transition to extrauterine life for the baby went really well. And it's just beautiful. I think if we saw this more often, if more birthers saw this more often, we would have that much more empowerment and success. And we would really feel the transformation that birth offers for everyone. So I love this image. And I love that she's just so shocked by it. Like, it's not her first baby. And she's still like, what? I really love it.
Yeah. I was just going to say, I feel like this vlog is the perfect example that a mom births their baby. Like, a doctor doesn't birth their baby for her. She was in the driver's seat the whole time. Her midwife helped out, but like, she just had total control and made it happen. I love that example.
I love that example too. And like, the midwife was in the role that really midwives should be in, which is playing a supporting role. We're not the center of the scene. Like, unfortunately, in Western obstetrics, doctors have sort of driven the car. They've been in the driver's seat. They've been in the real center of the experience. First of all, they're standing over someone laying in bed. They're fully dressed. The birther is in gowns. There's a real power imbalance. And what I really love about unmedicated, normal, natural, safe, community-based midwifery is that we support the birthing person to be in the center of the experience. And we're the supporting characters. And I really, really, I love that perspective. And this is such a good example.
Way to go. Hi. Oh my goodness.
Her face.
So they're trading out the wet towels for some dry ones, help preserve some baby body heat.
Oh, she's so sweet. She's so sweet.
Oh, she is so sweet.
Oh my gosh. Thank you, Lord.
But what we can see from this part of the video here is that number one is that her placenta is not ready to deliver because there's no blood in the water. And also, she probably didn't tear, or if she did, it was so minimal, because bleeding is only a result of either the placenta letting go or of a tear. And so it's a really good sign when there's no blood immediately afterwards.
What's your take on the fact that the baby hasn't made any noises yet?
That's a great question. And midwives are evaluating babies in the first few minutes of birth using a score called the Apgar Score, which stands for appearance, which is like the baby's color, pulse, the baby's heart rate, grimace, or the motions the baby's making with its face, activity, or the baby's tone in the muscles, and then respirations, the baby's efforts at breathing, those initial breaths. And so we give a score for babies in these 5 areas, 0 being absent, 1 being like partly there, and 2 being like fully appropriate and normal for a newborn. And so looking at this baby, the baby has not made sound yet, but sound is actually not one of the assessments in the Apgar score. So you might have heard babies getting a 9 or a 10. A 9 or a 10 means that baby is fully transitioned and is in their body and here and doing well. Lower scores than that means that the midwife needs to take some action to help the baby transition well. And looking at that baby from the outside, I'm not taking heart tones and I'm not listening to respirations. So that part is just really a guess on my part. But I did hear the heartbeat minutes before the baby was born in the 140s. So the likelihood that there's going to be a real distress in the heart rate is really unlikely. Also, the baby has a pretty normal color, a pink tone, a pink color to the skin, which means that it's very unlikely that heart rate is below 100. So that means the baby will get 2 for the heart rate. The baby was making some grimace motions, scrunching its face. So that feels like a 2 to me. The color is a 1 or a 2. The body is pink. The hands were kind of blue, bluish. So maybe a 1 in that score, but still really good normal color. I believe that baby was making some respiratory efforts. I could hear a little bit. I'm not sure if you could, Bekah, but I could hear a little bit of those sounds. And then the most convincing part that this baby is doing well is its tone. So babies who are in their body, are strong and have resources, they have tone. Their muscles are pulling in to make that kind of fetal position, even though they're out in the air. Babies who are floppy are really not doing well. So you can see this baby's hand is up by its face and its legs are brought up into its chest. And that tells me that the baby's doing really well. So I would probably give this baby an 8 or a 9 Apgar. And that isn't even at 1 minute old yet. We're still in those minutes before 1 minute. And we officially do the Apgar score at 1 minute, 5 minutes, And if the 5 minute isn't 10, we also do it at 10 minutes. And if the 10 minutes isn't 10, we would keep doing it every 10 minutes until we got a better score or until we transferred that baby for evaluation at the hospital. So this baby looks great to me. I have absolutely no worries. And it's a real kind of a myth that babies have to be crying to show that they're okay. Certainly, a baby who is crying is doing well. That isn't a negative thing, but they don't have to. And in fact, we see in midwifery many normally born, especially waterborne babies, are warm and they're still being touched and held by their mother, just like when they were on the inside. And there's generally not bright light shining in their eyes. They're not experiencing any pain. They're welcomed and held and loved and wanted by their parents. What do they really have to cry about, right? There's not really anything negative in their little baby life yet. So so many of our homeborn, naturally born babies, they actually don't cry, and we don't see that as a bad thing at all, because again, we have these other qualifications where we can evaluate baby's health. Does that answer your question?
Yeah, totally.
Yeah.
Oh, and there we go.
There's a cry.
Yeah.
It was all of a sudden like go ahead, and then I felt a pop and a drop. Like the side.
Pop and a drop. I think they write songs about this. They're all about your baby coming through your pelvis. The pop was probably the baby's the water breaking, which is great. So here they're getting ready to clamp and cut the cord. And this really isn't really necessary at this point. We can wait till the cord stops pulsing. We can wait till the placenta's even out. Midwives tend to weigh babies in these comfy cloth scales instead of on flat surfaces. We measure baby and check all their reflexes, which is what's happening here. And look at that nice, perfect baby with an almost exactly perfectly round head because he came out so quickly. And of course, we love skin to skin. Always recommend that. What a great video. Well, I'm so grateful that we got to review this. I think Sarah Therese has a beautiful story, and she did such a great job making this beautiful video. And I enjoyed watching it with you, Bekah, so much. And I hope that we do many more of these. Thanks again for all your great questions and your input. And I hope we do this again.
Thanks for your wisdom.
Well, as always, take really good care of yourselves. You know, we need midwives. We need more midwives in the world. So if you know a midwife, send them your love. And midwives, please take as good a care of yourself as you take of your lovely family.